So here are some disorders that are in the objectives of the lecture that weren't covered. We have congenital hypothyroidism and congenital adrenal hyperplasia. These are the non-metabolic disorders. So we said we have 17 disorders in the screening test. 15 are metabolic and 2 are not. And these 2 are the non-metabolic ones. طيب خلينا نشوف congenital hypothyroidism. Here is a summary of each of these from AMBOSS. So let's go through these together. So the epidemiology of congenital hypothyroidism worldwide is 1 in every 2,000 newborns. That is surprisingly a lot. So the etiology, it could be either permanent congenital hypothyroidism or transient. Hold on a second. Okay, or transient. What do we mean when we say transient? It means that there's hypothyroidism because we have antithyroid antibodies that came from the maternal serum. So they are transplacental transmission of maternal antithyroid antibodies, and which would cause destruction, autoimmune destruction to the thyroid. بمجرد ما تروح هذه الانتيبوديز يصير في recovery of the thyroid. عندنا fetal iodine deficiency syndrome. This is congenital hypothyroidism caused by iodine deficiency in utero. It's very rare in iodine sufficient areas. So why is it transient? بمجرد ما نعطي الأيودين خلاص الحمد لله. بس إحنا يهمنا هذولي. إحنا يهمنا هذولي. Permanent congenital hypothyroidism. So we have, it could be either primary congenital hypothyroidism or central congenital hypothyroidism. Central معناته في البرين معناته الأفكتد هو pituitary gland, which is rare. أما primary فإت's the defect in the thyroid gland itself. We have either thyroid dysgenesis, يعني في underdevelopment of a thyroid فهي ما قاعدة تنمو، سواء كان عندنا hypoplasia أو dysplasia في الخلايا يعني غلط اللي موجودة or ectopy. So عندنا ectopic thyroid ما هو في مكانه الصح، معناته ما يعمل على في الأكسس الصح ولا يسوي وظيفته المفروض يسويها. أو عندنا thyroid aplasia يعني ما في athyroidism. أو ممكن يكون عندنا hereditary dyshormonogenic goiter. فهنا مو في الثايرويد المشكلة، عندنا مشكلة في صناعة الهرمون الخاص بالغدة الدرقية. So عندنا thyroid hormone synthesis defect. It's most commonly in thyroid peroxidase, so هنا defect, and leads to thyroid hyperplasia and goiter. So صار عندنا hyperplasia, صار عندنا goiter, صار عندنا negative feedback loop causing us hypothyroidism. So إحنا what we screen for is primary congenital hypothyroidism. Okay, هذا معلومة هنا. Let's highlight it together. Congenital hypothyroidism may occur as part of another condition or genetic syndrome زي مثلا في Down syndrome. Down syndrome also يكون عندهم تبع syndrome hypothyroidism. طيب onset at birth ما يكون عندنا any features. ليش؟ لأن transplacental عندنا maternal T4 crosses the placenta ويعطي الطفل بالثايرويد هرمون اللي يحتاجه. فالfeatures develop over weeks to months if hypothyroidism is untreated. فإحنا we screen it قبل ما نشوف أي أعراض عشان نمنع development ونقدر نعالجه بمجرد ما يكون عندنا نتيجة السكرينينج. الكلينيكال فيتشرز في الأطفال تشبه اللي نشوفها في الكبار حق الهايبوثيرويدزم. So hypothermia, bradycardia and constipation. وبعد ممكن يكون عندنا مشاكل في النمو نفسه. احنا نعرف انه hypothyroidism causes weight gain in adults، لكن في الأطفال يلاحظون انه طولهم متأثر أكثر من وزنهم. And specific neonatal features اللي تتميز عن الكبار. Then أول شيء umbilical hernia. أول شيء you can see it over here. So هنا عندنا شكل طفل with mild stigmata. هنا يكون ماركت ستيغما، فعنده يعني شكل أوضح، وهذه صورة على طفل واقعي. زي ما تشوفون عندنا umbilical hernia, prolonged neonatal jaundice, hypotonia, decreased activity and poor feeding. So كله زي lethargy. Hoarseness of voice is characterized هنا as hoarse cry. Coarse facial features عندهم macroglossia، يعني يمكن مو مرة واضح هنا macroglossia. Large posterior fontanelle. Mottled skin. So mottled skin, what is this? It's a pattern موجود في الأطفال. زي مثلا هنا تشوفون هذا الطفل، تلاحظون هنا كأنه عنده زراق أو كأنه منقط. هذا ممكن الحين يكون طبيعي في بعض الانفنتس، لكن إذا كان significant أو associated with other features يخلينا نشك إنه hypothyroidism. فيصير لون بشرتهم كأنها منقطة mottled، يكون سواء يعني في زراق، في بياض، في لون وردي. So كأنه في decreased perfusion. And we also have abdominal distension. ممكن هنا ما هو مرة واضح بس ولا يمكن mild، لكن يكون هنا أوضح لما يكون marked features. And also دائما قلنا لو شفنا any congenital anomaly لازم ندور for other anomalies: cardiac, renal, gastrointestinal or skeletal، موجودين في vectral اللي أخذناه في pediatric surgery. طيب if it was severe or untreated ممكن يأثر على الديفلوبمنت حقه within the short stature اللي ذكرناه قبل, intellectual disability and even hearing loss. Most children with congenital hypothyroidism are asymptomatic at birth because maternal thyroid hormone crosses the placenta. So newborn screening is essential to allow early treatment and prevent irreversible intellectual disability. هاي قلناها. And also إذا تحبون تحفظون congenital hypothyroidism لها 7 P's. These are pot-bellied, abdominal distension, pale or mottled skin, puffy-faced, protruding umbilicus, umbilical hernia, protuberant tongue or macroglossia, poor brain development أو هذا إذا كان عنده intellectual disability, or prolonged neonatal jaundice. Pot-bellied, pale, puffy-faced, protruding umbilicus, protuberant tongue, poor brain development, and prolonged neonatal jaundice. So, what is the screening we do? First of all, it's indicated in all infants, and then it's routine. The method is using our heel prick between 24 hours and 1 week of life, preferably زي ما قلنا أول 24 to 48 or 48 to 72 hours. هذا أحسن وقت. What are we measuring? We're measuring TSH and or T4. So based on هذا بنشوف هذا. ممكن يكون عندنا increased TSH levels with low T4. So هذا البrimary, suggesting congenital hypothyroidism. And we need to confirm the diagnosis. لأن screening test ما هي confirmatory. نحتاج we confirm the diagnosis with a thyroid function test. أما إذا عندنا normal TSH and T4 بس كان عندنا symptoms, so we're going to screen for إذا كان the high risk features. One infant with high risk features will repeat the screening for hypothyroidism at 2 to 4 weeks of age. I don't know how relevant or how يعني important this is لنا الحين بس أيوة. So the initial management, the following outlines. Okay, so the approach, first we need to consult with pediatric endocrinology عشان نسوي diagnosis ونشوف suitable management plan. So sometimes before we confirm a diagnosis kind of super low levels لازم we do immediate treatment. So إذا كان ال TSH very high, so more than 40 milli international units per liter، على طول start levothyroxine قبل ما حتى قبل ما يطلع الconfirmatory. أما لو كانت TSH يساوي 40 milli international unit or less فنستنى thyroid function test. So the cutoff point هنا عندنا 40. We're going to obtain thyroid function tests, ideally within 24 hours, and begin management based on results. So when do we start levothyroxine? We start levothyroxine if the patient has overt hypothyroidism. إذا كان normal free T4 بس ال TSH حقهم more than 20. أو إذا عنده low or normal TSH and low T4. So هذا يقول لنا عندنا central cause. هذه كلها تتطلب إن نبدأ levothyroxine. So إذا كان عندنا overt hypothyroidism أو إذا كان عندنا subclinical اللي هو الnormal T4 بس ال TSH عالي، أو إذا كان عندنا central hypothyroidism with low TSH and low T4. Now, if the patient has normal free T4 but elevated TSH, but it's less than 20, the more than 20 we start, but if it's equal to 20 or less, we'll monitor the thyroid function every 1 to 2 weeks, and we'll begin levothyroxine if the TSH remains more than 10 after 4 weeks of age. Again, heavy details, but I'm just covering everything just in case. And we may consider additional diagnostic studies. We may do a hearing evaluation لو احنا يعني concerned about hearing loss. levothyroxine ما بدخل في الديتيلز كثير. بس our aim is to normalize T4 levels and TSH levels. T4 levels, and here direct causes of symptoms. Want to normalize them as soon as possible in 2 weeks. TSH can wait for 4 weeks. Now, if a child has permanent congenital hypothyroidism, يعني هنا الpermanent سواء عند الأبلاسيا hypoplasia يعني مشكلة في الثايرويد نفسه، we may consider lifelong hormone replacement therapy. بعدين عشان we confirm قلنا ما يكفي we confirm بالimaging لو كان indicating إنه في مشكلة عندنا في الhypothyroidism عشان نشوف إذا هو عنده thyroid dysgenesis. Ultrasound is good, there's no radiation but sensitivity is low. ممكن نسوي iodine uptake scintigraphy بس في radiation exposure, and also it must be performed when the TSH is elevated. Okay, I'd say this is enough. Follow up. We need to do regular follow-up throughout infancy and adulthood نشوف growth and development that could be affected لو كان severe. We're going to adjust levothyroxine كل مرة عشان نتأكد. قلنا بنشوف بعد نبغى يتعدل في أسبوعين أو 3 في أسبوعين لل T4 و4 أسابيع لل TSH. and بنسوي retesting عشان نشوف إذا هو permanent congenital hypothyroidism سواء بالسيروم سواء بالimaging وسواء if we discontinue levothyroxine at 3 years of age نشوف إيش يصير. Congenital hypothyroidism. Now, what about congenital adrenal hyperplasia? If you remember, غطينا جزء منه في سنة ثالثة، كنا نتكلم عن adrenal glands و wait, hold on. So first, congenital adrenal hyperplasia is autosomal recessive defects in enzymes that are responsible for the production of cortisol. It means that في defects فيهم بس عندنا low levels of cortisol and the lack of negative feedback to the pituitary, increased ACTH leading to adrenal hyperplasia. So صار عندنا adrenal hyperplasia but still No cortisol. Now let's give it a little sad face. So our pathway here, everything that's produced in the adrenal glands relies on our main factor, cortisol. We have, based on the zones of the adrenal glands, ممكن ننتج mineralocorticoids, glucocorticoids, and androgens. Mineralocorticoids like aldosterone, glucocorticoids like cortisol, and androgens like estradiol and DHT. I forgot its real name. كلهم يحتاجون كوليسترول. طيب هم يمرون في pathways كثيرة، بس وفي 3 enzymes ممكن تكون affected. فبased on the affected enzyme ممكن ينتج لنا أشياء مختلفة. مثلا خلونا نقول إنه هنا صار عندنا ال 17 alpha hydroxylase. Let's say هذا affected. طلع له X، طلع له X. معناته can we get glucocorticoids? No. طيب إذا ما عندك glucocorticoids نحتاج الخطوة هذه عشان نقدر يصير عندنا androgens. فهاي يصير عندنا androgens؟ No. فنشوف الحين لو كان عندنا ال defect في ال 17 alpha hydroxylase هنا عندنا low cortisol, low androgens, and low aldosterone. Now why is that? And what the hell is 11-deoxycorticosterone? Now خلينا نشوفها هنا. So هذا هو ال 11-DOC. Now احنا قلنا الباثويز هنا مقفلة، هنا مقفل، هنا مقفل، هنا مقفل. ال only pathway هو هذا، نقدر نمر من هنا. one of شو يسمونها؟ one of the byproducts في هذه العملية هو ال 11-DOC. 11-DOC بعدين مع ال alpha beta hydroxylase بمساعدة الالدوستيرون سيستم الانجيوتنسين 2 بس بمساعدة الانجيوتنسين 2 يصير عندنا الدوستيرون. لكن في هذه الحالة يصير عندنا يصير عندنا كل الكورتيزول كل الكوليسترول قاعد يتحول في هذا الباث الوحيد، فصار عندنا elevated DOC. فالDOC هو ال precursor of aldosterone. It has similar effects as aldosterone in this immature state. فيجي الانجيوتنسين يشوف والله في كفاية من هذا، والصدق قاعد يصير عندنا hypertension. So I'd say خلاص let me not do anything. So it's not doing anything. يصير عندنا elevated DOC. The aldosterone was like, what the hell? That's literally not me. But no one cares. So هو في هذه الحالة oh my god so في هاي الحالة الالدوستيرون مظلوم. And في كل الحالات actually مظلوم لأنه في كل الحالات there is low aldosterone. Aldosterone can never win. فلما نشوف الديفكت في 17 alpha hydroxylase عندنا decreased cortisol, decreased aldosterone, decreased androgen, and the only one winning here is the 11-DOC. ال 11-DOC هو الوحيد اللي يكون elevated في مين؟ 17 alpha hydroxylase. طيب هنشوف الحين لو مسكنا شيء ثاني. let's نمسح. نرجع. Okay. Let's try blocking something else. What if we block the 11 beta hydroxylase? So we blocked 11 beta. We blocked 11 beta. معناته هل صار عندنا aldosterone? No. صار عندنا cortisol? No. إيش الوحيد اللي قاعد يصير عندنا في 11؟ صار عندنا الأندروجينز، هي الوحيدة اللي قاعدة تزيد. So seeing هنا beta hydroxylase 11 beta hydroxylase decreased cortisol, decreased aldosterone. وعندنا increased androgens والDOC. If you see هنا we blocked 11 beta hydroxylase معناه يشبه ايش؟ يشبه انه we blocked angiotensin meaning oh my god too many pens meaning عندنا 11 DOC again. هنا في bias لأنه 11 beta hydroxylase is biased لأن هذا oh my god أنت 11 بعد oh my god what's up يعني يسلمون على بعض. they're like oh my god لا خلاص إحنا اثنين لازم نكون we need to rise together. So عشان البايس هنا we have also increased 11 DOC. تتذكرون يزيد الأندروجينز 11 so واحد وواحد الذكر والأنثى. الذكر والأنثى. So عندنا increased androgens. طيب آخر شيء let's see if we block, let me just erase. What if we block 21 hydroxylase? لا alpha ولا beta, interesting. طيب we block here and we block here. So now no cortisol, no aldosterone, we only have androgens. ما هنا عندنا 11 دي او سي لا لأنه we blocked قبل ما يجي. So خلي يكفي grade yeah 11 دي او سي. So now we have مع 20. Oh you're a beta. Okay. Fine. So 21 beta hydroxylase, we have decreased cortisol, decreased aldosterone, decreased 11 DOC, finally, and we have increased androgens. Again, we can remember this. إنه هنا في androgens هنا الذكر والأنثى قلنا هنا two genders, one family. وال11 يكون في increased 11 DOC عشان 11. طيب the most common, so قلنا autosomal recessive, the most common is the defect in the 21 beta hydroxylase. قلنا one family واحنا قاعدين نتكلم الفاميلي بيكون عنده baby baby tough luck baby. فهذا most common للcongenital adrenal hyperplasia. Now that took a while. So let's see the clinical features. Now هذول اثنينهم البلد pressure هنا hypertension عندنا 11 beta و 17 alpha عندهم increased 11 DOC which acts similarly to aldosterone لكن كلهم عندهم low aldosterone. okay. أما 21 beta hydroxylase فعنده hypotension لأنه ما عنده هذا 11 DOC. ال 17 alpha hydroxylase بيكون عندنا delayed puberty whether it was primary amenorrhea or sexual infantilism معناته ما عندنا ال secondary sexual characteristics. أما في هذولي فقلنا عندنا increased androgens وandrogens هي الهرمونات الذكورية. So female pseudohermaphroditism is لما يكون intersex اللي عندهم two ambiguous genitalia. So هنا pseudohermaphrodite يكون مو ambiguous genitalia عندهم both الفيميل والميل genitalia. Pseudohermaphroditism إنه we think إنه عندها يعني الvagina والpenis بس nope that is her clitoris which is enlarged. and or male external genitalia along with a uterus and ovaries. فالinternal organs are female. هذه هي female. الميل جينوتايب بيكون عندنا increased androgens, increased هرمونات ذكورية معناته يبلغ بدري مسكين. and normal genitalia at birth. طيب إذا كان عنده ال 17 alpha hydroxylase الميل هذا فإحنا قلنا إنه عنده less androgens معناته بيكون عكس هذا فيكون male pseudohermaphroditism. So he has female external genitalia with a blind ending vagina or intra-abdominal testes at birth. So ما تكون undescended عشان كذا هي intra-abdominal. Or delayed puberty and sexual infantilism. يعني decrease the secondary characteristics. Okay. Oops, وين راح المايك? There it is. Erase, erase, erase. Other features, عندنا hypoglycemia. Let's highlight them. Hypoglycemia, an adrenal crisis, vomiting and diarrhea leading to dehydration, failure to thrive, and hyperpigmentation in areas that are not exposed to sunlight. So I had palmar creases, mucous membranes, oral cavity, genitalia, and they're a common feature in all forms. They had hypoglycemia, adrenal crisis, failure to thrive, and hyperpigmentation. So infants may present with shock within the first few weeks of life because of severe dehydration due to an adrenal crisis and salt wasting due to hypoaldosteronism. So في other different types. عندنا الكلاسيك والنون-classic. يعني نركز على 21 beta hydroxylase deficiency لأنه هو most common. الكلاسيك, so it is detected by neonatal screening. It is severe. Oh, this one, the classic one, is the one. Why did I say that? So it is more severe, and this one is the one detected by neonatal screening. But it is less common. The onset of symptoms are early. They occur in the neonatal period or early infancy عشان كده موجودة داخل السcreening. والmanifestation هو salt wasting type اللي فيها dehydration, failure to thrive, vomiting والشوك. وعندنا الambiguous genitalia لأنه قلنا في هذا عندنا increased androgens. وعندنا non-salt wasting type, no shock. Males present with precocious puberty, more androgens, and females with ambiguous genitalia. So just in عندنا classic, it's severe, detected by neonatal screening. It has an early onset. Two types, salt wasting, which we may present with shock, or non-salt wasting. اللي هو الأقل. اثنينهم فيهم نفس الفيتشرز اللي شرحنا حق 21 beta hydroxylase. عندنا non-classic, the deficiency is mild, it's more common, and it has a later onset. So that's why it's not detected by neonatal screening. So because it's mild, so there would be normal genitalia at birth, but precocious puberty, specifically in males, acne, infertility in females, and females may have irregular menstrual cycles and hirsutism, signs of hyperandrogenism, and some may even be asymptomatic. So just إن إحنا نقيس الكلاسيكال. طيب. Diagnosis, I'm going to skip these. بس إحنا أهم شيء عندنا screening والtreatment. So we need replacement therapy, glucocorticoid replacement therapy for all forms, and كلهم عندهم decreased cortisol. Our aim here is to replace deficient hormones and reduce excess androgen production. And this would be a lifelong and daily regimen. Specific treatments بعدين based on اللي ناقص عندنا نعطيه. So في 21 beta hydroxylase deficiency بنعطي mineralocorticoid in the form of fludrocortisone. وعشان في حال صار عندنا salt wasting بنعطيهم sodium chloride table salt supplements during infancy and childhood. طيب لو هو 11 beta hydroxylase deficiency بنعطيه spironolactone to block mineralocorticoid receptors. عشان احنا قلنا هنا انه بيصير عنده 11 عنده high DOC. We're going to block these receptors عشان ما يصير يقلل عندنا أو it suppresses aldosterone. And we're going to reduce dietary sodium intake. كل هذا عشان بس نبغى الRAS system يستوعب hello ترى stop suppressing your function, just release angiotensin 2. آخر شيء 17 alpha hydroxylase deficiency. Again we're gonna عندنا elevated DOC. So بنعطي spironolactone, estrogen replacement therapy عشان androgens, and reduce dietary sodium intake similar to هذا. If we have salt wasting, so fluid resuscitation with intravenous normal saline, intravenous dextrose if patients have significant hypoglycemia, immediate administration of glucocorticoid replacement therapy. When non-classical إذا هم symptomatic نعطيهم hydrocortisone until 2 to 3 years post-menarche for girls and early to mid-puberty in boys. نعطي OCPs in women. أو ممكن نعطيهم glucocorticoid therapy. In men usually no treatment is required. Okay. Yeah, so this is it for both topics اللي ما كانت مغطية. And there we go.